Honorable Ministers, Excellencies, dear colleagues and friends, thank you for joining us for today's briefing, and I would like to especially welcome Dr. Vardhan, the Chair of the Executive Board, who has also joined us. Today, we will be hearing about the experiences and lessons learned fighting COVID-19 from ministers and senior experts from member states, Mongolia, Nepal, Bahrain, Hungary, and Barbados. And I would like to thank all these countries presenting today, the ministers, for agreeing to present and sharing their experience. WHO is continuing to support member states with the evidence-based technical guidance you need to protect your people. Just in the past week, we have published the following documents: updated guidance on clinical management of patients with COVID-19, operational planning guidelines to support country preparedness and response, a monitoring and evaluation framework, a scientific brief on smoking and COVID-19, a protocol for conducting age-stratified sero-epidemiological investigations, and a protocol for the assessment of risk factors for COVID-19 in health workers. And we urge all member states to read and implement this guidance, and we're committed to working with you through our regional and country offices to adapt it to your unique circumstances. And yesterday, we had the pleasure of launching the WHO Foundation. This is a historic moment for WHO as part of our ongoing transformation. The WHO Foundation is the fourth piece of our resource mobilization, the first WHO investment case, and the first WHO Partners Forum. The WHO Foundation has been created as a way to generate funding from sources we have not tapped before, including the private sector, major donors, and the general public. Until now, WHO has been one of the few international organizations that has not received donations from the general public. By broadening our donor base, we can generate funding that's both more predictable and more flexible, which is critical for WHO to fulfill its mission and mandate. The establishment of the WHO Foundation comes after 2 years of hard work, when we started the formal consultation with you and other stakeholders on February 2018. And it builds on the success of the COVID-19 Solidarity Response Fund, which has provided powerful proof of concept for WHO Foundation. In just 2.5 months, the Solidarity Response Fund has raised more than $214 million from more than 400,000 individuals and companies. These funds have been used to buy lab diagnostics, personal protective equipment, and to fund research and development, including for vaccines. The Solidarity Response Fund will continue to receive donations to support WHO's work on COVID-19, while the WHO Foundation will help to fund all elements of WHO's work and be fully aligned with our priorities. And I would like to use this opportunity to thank all member states for your inputs and guidance that led us to the establishment of the WHO Foundation.
It's now my pleasure to give the floor to the first speaker. That is from Mongolia, Her Excellency Ms. Saran Garel Davajonsky. You have the floor.
To the hosts and others in Geneva, Dr. Kasai, the Regional Director, dear colleagues around the world, a very good morning, good afternoon, and good evening. Let me share my presentation on Mongolia's response to the COVID-19 pandemic. As 28 May, we have 161 confirmed cases with 43 cases reported as recovered. All cases are imported from travelers from overseas. Mongolia is in the stage 1 of transmission with no evidence of localized transmission. Mongolia has taken early non-pharmaceutical interventions, including school closures, travel restrictions since January. At the same time, we also implemented intensive case finding, contact tracing, early detection, and community engagement measures. The early preventive and containment measures helped us buy valuable time for preparedness. These are the highlight of the COVID-19 preparedness and response in Mongolia. We have carried out the whole of government response to preparedness and response. In line with the operational coordination mechanism, sectors shared event information, conducted risk assessment 8 times, activated incident management system at all levels across all sectors. Risk assessment results revealed the high risk of insufficient control capacities with available resources. Forecasting of essential supplies has been estimated for national level as well as for each province. Based on the results of the risk assessments and logistical forecasting, we were able to increase domestic funding. As a result, ICU bed capacity has been markedly increased than it was before. We have also taken the whole of society approach. For COVID-19, we started proactive risk communication and public listening early in our work. A critical aspect of COVID-19 risk communication strategy is the daily government and WHO joint risk briefing, which was activated early. Multi-source information is analyzed, communication measures are adapted to the local context and culture and customized to communities and settings. Community engagement through active listening by dedicated hotlines, regular feedback is at the core of COVID-19 to improve public acceptance and compliance. Recently, at the initiative of Prime Minister of Mongolia, the government conducted a 3-day simulation exercise to test our national capacity for health, emergency preparedness, and response. The simulation exercise helped us identify areas that need improvements and draw recommendations from the lessons learned. We consider the simulation exercise as a key pre-disaster activity to test system readiness and multi-sectoral coordination. This slide shows how the citizens were involved in the full-scale simulation exercise. A downtown area with nearly 5% of the country's entire population was put on lockdown. Effective risk communication led to public support and compliance. The simulation exercise and other preparedness measures allowed us to test our national capacity during the pandemic. The establishment of coordination mechanisms for public health emergencies created a strong legal framework, and the exercise demonstrated opportunities to strengthen it further to ensure even greater multi-sectoral coordination. The Ministry of Health and WHO, along with partners from different sectors, are continuing our work to rectify gaps, address weaknesses, and improve capabilities. Mongolia has well-established healthcare service delivery system and infrastructure. However, no country can manage excess hospital influx. One important lesson we learned from the exercise is that plans and procedures mostly applicable to only stage 1. To increase hospital source capacity, local governments, social welfare, and state institutions were mobilized to prepare facilities such as hotels and resorts. With their support, Mongolia's forecasted needs for hospital beds during the pandemic peak have been met, ensuring that everyone would be able to get the care they need. Over 22,000 beds have been prepared in non-health quarantine facilities. These are Mongolia's experience and updates that I wanted to share with you, distinguished colleagues. Thank you for your attention.
Thank you very much, Excellency, for that excellent presentation. Thank you.
Thank you very much. Thank you.
It's now my pleasure to move to Nepal, where I have the honor to introduce the Chief Specialist, Ministry of Health and Population, Dr. Roshan Pokral, for your presentation. Dr. Pokral, you have the floor.
Thank you very much. Shall we share the screen? Yes, sir. Thank you very much. Honorable Ministers, Your Excellencies, friends, I take this opportunity to thank WHO for giving us this opportunity and allowing us to share our experiences in COVID-19 pandemic. And I'm grateful to you, Mr. DG, and your team for giving us this opportunity. So I'd like to start with Nepal experience in response to COVID-19 pandemic. At present, the Nepal situation is we have 4 deaths and around 886 cases till yesterday. Out of which 183 of them are discharged, and we still have around 699 of them in isolation in the hospital. As per our country's policy, all the positive cases are kept at hospital-based isolation beds. However, institutional and home-based isolation arrangement will depend upon the number of cases and the health system capacity to manage, which we will review continuously. 20% of the cases are discharged from isolated bed from the hospitals, as the results turned 2 negative results according to the WHO protocol. Nepal's average test is around 2,000 per million at present. So we have done around 60,000 PCR tests till date. And the distribution according to age and sex is we almost see that 80% of our cases ranges from 15 to 45 years of age, and around 90% of them are male, whereas 10% of them are female. This might be because we are diagnosing the cases who are usually coming from our border areas, and these people are young people working abroad. The trend we see in Nepal is we reported our first case on 24th January, and then there was a big gap. We couldn't, for around 2 months we didn't have any cases, but after around 75 days we found that from 1 the cases increased up to 100. Although we had imposed complete lockdown in the country from 24th March, because of that initially there were no cases, but as the lockdown loosened up, especially in our neighboring countries, then we see drastic increase in cases. From 100, every doubling of the cases usually in the initial phases were 7 days, now it's doubling in around 5 days. And in this period, we have also increased the PCR facilities, the rapid testing RT-PCR facilities from 1 in the initial days to around 20 in the country now. So we have 20 PCR machines in different parts of the country in order to find out or diagnose the cases of COVID-19 now at present. The case distribution, as you can see through the map of the country, the case distribution is usually on the Tarai regions, and these Tarai districts are adjoined to India. So almost all the red parts of the country, ranging from the eastern side to the western side, which have direct connection to Indian borders, we have found a lot of cases in these areas, and especially province number 2 and province number 5. These, all the areas of province number 2 and province number 5 has adjoining borders with India. So we see that around 80% of our total cases in these two areas, and this is slowly moving up. Thankfully, we still have certain around one-third of the districts which does not have any cases till date, but almost two-thirds of the districts we have seen that the cases are going up. The response what the government has done is we are very careful at our point of entry. We have set up health desks, especially at the airports. Borders has been remained closed since January 2020. The health desk is at the port of entry. So we are very concerned at the port of entry or point of entry, and similarly we have designated COVID hospitals and non-COVID hospitals. The COVID hospitals only deals with COVID patients, whereas the non-COVID hospitals deals with other facilities. Initially we had problem in segregating the COVID and non-COVID cases, so we had deaths from other diseases which could have been prevented. So we had to segregate our hospitals into COVID and non-COVID hospitals. And certain hospitals, the COVID hospitals have been labeled as COVID-1, Level 1, Level 2 and Level 3 hospital. So that we have isolation facilities in one level, whereas we have ICU and intensive care facilities in the second level, where oxygen supplies and other treatment facilities are there, whereas in the third level we have special cases where COVID patients needing other surgeries or other medical interventions are treated in the third level of the facilities. Then the laboratory services, we have expanded our laboratory services to 20 locations throughout the country, but we still are lacking behind because sometimes we have more collection of samples and sometimes it is taking around 2-3 days in order to give them the reports. Similarly, the surveillance and the case investigation part, initially we formed the case investigation and contact tracing teams from the central level. Initially it was quite easy to mobilize them throughout the country, but as the cases increased, we had difficulty in sending these CICTT persons to the local levels. So what we have done is, now we have distributed them at the municipality level so that they can move immediately once a case is diagnosed at that place, and the contact tracing can go ahead as soon as possible once the case is diagnosed immediately. The logistic part, at present we are thankful to our neighboring countries, especially China and India, for providing us with almost all of the logistics. We have bought some logistic also, but because of the scarcity in the international market of the logistics, we are still in short supply, and in the coming days I think it will be in a very short supply, especially of the reagents, PCR reagents, RNA extraction kits and the viral transport medium has always been in short supply, but we are managing till date. But in the coming days I think we will have to look into this very effectively in order to get this supply as soon as possible in the country, because we do not have internal supply of these things, so we'll have to get it from outside. So we are concerned about the logistic at present. The public health point of view, we are doing three things. At the main importance of public health is we are trying to communicate. We are working in the communication part. There are a lot of problems in the communication parts. We are trying to send health experts to different levels so that they can give proper communication to the local level people, especially about the physical distancing part, minimum of 3 to 6 feet physical distancing, hand and respiratory hygiene, especially the washing part, hand washing and use of sanitizers, and we have also established permanent use of masks while going outside home and especially in the workplaces. Similarly, the high-level coordination committee is there. The committee was activated immediately after the first case, and this high-level coordination committee is led by the Deputy Prime Minister, and there is also the Corona Crisis Management Center, which is a multi-sectoral action plan which involves the army, police and supply and other stakeholders and also the health ministry is prominently looking after it. Similarly, after the 24th March lockdown, we still are in the lockdown process, and this lockdown moves another 5 more days. Then we'll re-evaluate the situation of the country and try to loosen up some of the lockdown system, but it will not completely go against it. We will gradually open up certain non-essential facilities also after this lockdown closes. Next. So some of the good practices we have seen in Nepal are the essential services, and the supply has been continued throughout this lockdown period, and this has released production sites and essential workers. The major hydroelectric plants and other factories, bigger factories, are still doing their work, provided they maintain certain public health aspects of it, especially the social distancing part and use of masks. Similarly, the call center has been established to address public health concern. The call centers, we have seen that it has been very effective, as because the population cannot move out, they are using this call center to get whatever health concerns they have, and we are trying to solve them through these call centers, and sometimes we go for public health experts and allow them to talk to these people also, so that the call centers work effectively. Extensive focus is there on the communication part, especially to increase the awareness, promote public health measures, and to address the myths that are going on in the country. As because all the people are inside the house using the internet and other things, we find that there are sometimes certain unnecessary news coming, and we are trying to solve this through the central mechanism and addressing these also. A benefit and security package to the frontline health workers has been given, especially the health workers and security professionals are provided with additional incentive, life insurance, and going to the quarantine facilities after they complete a certain amount of work continuously in one facility. Obviously we do have certain key challenges. The main key challenges at present is the influx of Nepalese migrants, especially coming by the roads through the red areas, when what we saw initially. I mean, that is especially from India, and we have a lot of people outside Nepal working outside Nepal who want to come back home, and they require the airport facilities. So the influx of Nepalese migrants, both by the road and by air, will be a big concern to us. And we are expecting around 500,000 Nepalese to come to Nepal within 1 or 2 weeks' times, and we are still very shortage in our quarantine facilities. We do have quarantine facilities, but unfortunately their standard is quite low, and we collectively are working together to improve the quarantine facilities. Similarly, the stigma and the myth and the fear, especially to the health workers and also to the public, has been addressed. We'll have to address this as soon as possible. The availability of the logistics is also a big concern to us. Because of this, around 500,000 people coming to Nepal within a very short period of time. Thank you very much.
Thank you very much, Dr. Pokral. It's now my pleasure to invite the Chief of Health Policies and Programs, Supreme Council of Health from Bahrain, Dr. Mohammed Al-Shaban. Sir, you have the floor.
Thank you, Mr. Chair. Your Excellency, Dr. Tedros, Your Excellencies, Ministers, dear delegates, good afternoon, good morning, good evening, according to your respective time zones. Thank you for allowing us, and on behalf of the Ministry of Health in Bahrain, to share our experience in terms of combating coronavirus and our response management with regards to the disease. To begin with, just a quick context as to Bahrain. So Bahrain is a small archipelago made up of 33 islands in the Gulf, part of the Gulf Cooperation Council, and is a member state in the Arab League in the continent of Asia, with a small area of 780 square kilometers divided into 4 governorates with a population of approximately 1.7 million, according to the latest estimates, and a mean life expectancy of 77.2 years. Public healthcare is free and inclusive in Bahrain for all citizens and highly subsidized for residents. But in terms of the COVID-19 outbreak, it is free and inclusive for everyone in Bahrain. With regards to a quick look at the numbers, COVID-19 numbers. So as of 6 a.m. on May the 28th, this morning, we had 4,599 active cases of coronavirus, with the total cases that have tested positive since the first case on February the 24th, a little short of 10,000 at 9,768. And a 52.8% recovery rate at 5,154 recovered. We've reported 15 total deaths, that's a 0.15% case fatality rate. According to our adopted policies of intensive testing through PCR, we've conducted 291,880 tests as of 6 a.m. That's 171.7 per 1,000 of the population. And if I can turn your attention to the graphic demonstration on the right, we note that Bahrain has registered more total recoveries than total active cases, standing at 5,154 compared to 4,599 as of 6 a.m. today. A quick look at the sequence of events. So since the outbreak began spreading in the People's Republic of China and certain areas of Asia, Bahrain initiated a national task force to combat the virus on January the 26th, made up of representatives from different areas of government and the private sector in order to set policies to combat the virus, to ban or stop its entry and spread in the country. On February the 7th, we had testing stations at the ports of entry and restrictions for travelers to and from certain areas where the outbreak has spread. On February the 24th, we reported our first case, a young Bahraini man returning from the Islamic Republic of Iran, and he was in the country for 2 days before reporting any symptoms. Following the discovery of that case, the same night, there was a decision passed to close down all educational institutions and schools. And on February the 28th, we've established a 24-hour hotline with 7 different languages to respond to any questions or queries regarding COVID-19. On March the 10th, and due to the travel restrictions imposed both in Bahrain and in different countries, the task force initiated a repatriation program for citizens wishing to return to Bahrain. And on March the 17th, and because of the anticipated effects of this pandemic on businesses and shop owners and different industries in the kingdom, an economic package was launched, and this package included subsidies for payments for employees in the private sector, as well as payment for utilities, which I'll come to in a minute. And on March the 18th, the task force adopted a partial closure scheme of a 2 weeks on, 2 weeks off closure for all businesses and facilities and facilities of recreational activities. Now, following the assessment of these parameters, which I'll come to and allude to in a minute, as of yesterday, there was some ease of these restrictions, provided that there are certain guidelines that these businesses need to follow. So if you allow me to just go into a bit more details with regards to the mitigation measures. So like we said, the National Task Force was formed on January the 26th. And if we look at the response by sector, starting off with the public health, there was an inclusive and comprehensive testing strategy. A makeshift testing center was established in the heart of the capital with and satellite labs spread throughout the ports of entry and in different hospitals and health institutions in Bahrain, with a testing capacity of about 8,000 tests conducted a day. The public health team is also involved with contact tracing of every reported positive case in order to test the contacts and quarantine according to the protocols, as well as involvement in epidemiological forecasts and assessments of these forecasts in order to aid decision makers with regards to going forward with mitigation measures. There is also involvement in stocks and supplying these stocks with regards to testing and treatment for the different isolation centers. Medical team is also working around the clock, overseeing the isolation and quarantine facilities and continuously updating the treatment and discharge protocols according to the latest guidelines, while putting the plans to best utilize the beds available in these facilities. Like we mentioned earlier, a foreign affairs team was also involved in imposing the travel restrictions and repatriating the citizens that are stuck outside and were wishing to return, as well as international collaboration with different global bodies. A security team was also involved in all these activities with regards to transporting patients to health facilities to the National Ambulance Center, or with regards to securing the facilities by providing the Ministry of Interior employees to aid in securing these facilities and upholding the rule of law. The economics package that we talked about in terms of aiding in the payment, salary payment of employees working in the private sector because of the effects of the lockdown or the partial shutdown on these small and medium enterprises, as well as paying all utility bills for all residents and citizens of Bahrain for 3 months and deferring loan payments for 6 months. With regards to education, like was mentioned earlier, the decision was to close down all educational institutions, be it schools or higher educational institutions, the very evening that the first case was reported, provided that the first case was a school bus driver. Despite that, there was an initiative by the education team to continue providing lessons and educational lectures through an online platform and dedicating a national television station to broadcast these lectures on national TV and then uploading them online while continuing with examinations and conducting classwork through online platforms. The task force realized the importance of social engagement from the outset. Society's buy-in was crucial for the task force, and that's why a comprehensive media campaign was launched from the very beginning with the launch of the task force in January. The campaign was launched in 7 different languages. 2 spokespersons were elected that related to the people, and they are the ones delivering this information through weekly live press conferences and with an adoption of complete transparency with regards to the number of cases in order to find any rumors that might arise. And finally, an environmental team was also involved with regards to the disposal of waste and waste management and protocols regarding to the burials of those that were deceased because of the virus. I just want to shed light really quickly on the bed capacity. So some centers were already existing hospitals that were transferred into COVID-19 facilities. Others were newly erected, either field hospitals or buildings that were used for other purposes that were transformed to COVID-19 facilities. So the protocol in Bahrain now is that all positive cases need to be admitted to a facility. The facility can either be a treatment facility or an isolation facility. The bed capacity for all isolation centers is 7,300. That's 4.3 beds per 1,000 of the population. For the ICU, it's 373 beds. That's 22 beds per 100,000. We also have quarantine centers for contacts and people who cannot quarantine themselves due to living conditions or otherwise at their own homes. So we provide that service as well, free of charge, for 2,930. That's 1.7 beds per 1,000. For others who opt to quarantine at home, we have a tracker that is being followed electronically through the public health team to make sure they abide by the quarantine guidelines, and they are released in time, provided that they don't provide risk of infection to the population. Finally, I just want to touch on the assessment parameters of these mitigation measures. So we've, in order to make sure that our mitigation measures are working, we've set certain scoring mechanisms with certain parameters that we look to in order to make sure that we are, so to speak, going on the right path. First of all is the ratio of recovered versus new cases, and ideally we wanted to keep that at 1 or higher for 7 days at a row. The cumulative growth rate, keeping that growth rate less than 100% within 14 days. Contacts per positive case, ideally less than 4 contacts per case that test positive. The bed occupancy of symptomatic patients, ideally less than 10%. ICU admission rate, ideally less than 5%. And the R0 prediction, again, ideally less than 1. And the economic impact, ideally none. According to the scoring that we've established, with these parameters, Bahrain has decided to ease the restrictions on May the 27th, that's yesterday. And we started by opening up businesses or allowing them to remain open after the 2-week on and off protocol that we've adopted. And we've re-established the opening as well of hair barbers and hair salons and outside facilities for recreational and sport activities. Religious facilities remain closed, and restaurants also remain closed, as well as indoor gyms and pools also remain closed. But everything that has opened, we've launched strict guidelines for these facility owners to follow in order to make sure that we quell any risk with regards to spreading the disease. So that's it in a nutshell with regards to the Bahrain experience. Thank you.
Thank you very much, Dr. Mo, for that excellent presentation, and I think we're very much enjoying the variety and rich presentations, and also their concise presentation is much appreciated. Now time to move to the European region, and my pleasure to introduce the Minister of Health, Excellency Professor Horváth from Hungary. You have the floor. Thank you.
Dear Director General, dear colleagues all over the world, thank you very much for making this meeting available for us, and we really appreciate that we can share our experiences with COVID pandemic. And albeit, as you will see on the next slide, that we counting our date time from the 24th of January, but let me go back to the New Year Eve. And this New Year Eve was a special one all through the world. It brought a certain uncertainty. It brought us feelings when we learned about, on the last day of the last year, that there is a new virus or something around, a new type of pneumonia. And with this uncertainty, that was a very good example of the activity of the WHO and of the government of China, how open the whole process was in January. So let me say a big thank you to the WHO and also to China to helping us all in the other parts of the world to prepare. I will tell you ABC, because probably this is the 3 words how I can summarize for you the Hungarian actions. And one of the, probably the most important, what I would say is act in time. If we are thinking about the 3 different approaches, what could have been chosen for preparing of this pandemic, one was to act in time and try to save as many lives as, and try to prevent cases, try to prevent the spread of the virus. The other, I would call something kind of wait and see. Let the disease go on to some time and act accordingly later on. And the third one, what we don't talk too much about probably, but what we learned that there were expectations for herd immunity, and there was discussions and a kind of let it go approach. Let it go, and it probably takes up to herd immunity. Here in Hungary, we took a very active process. We took an active choice. We wanted to prevent and we wanted to save lives. And when the first case appeared in Europe and was reported from France, it was very much close to the WHO decision to bring attention to this virus and the potential human health threat on the 24th of January. On the next day, we started our preparation in the healthcare sector. A few days later, the 29th of January, the Hungarian government put together a Hungarian operational group which included everybody else through the whole government, not only the healthcare sector any longer. It was led for a few weeks by the Deputy Prime Minister, and later on in March, the Prime Minister took it over. And it's led by the Prime Minister at yet. When the next day, the public health emergency of international concern of the WHO was brought by, we felt that yes, the international society confirms the actions that we already chosen. And we were very happy as well, of course, that a very well appreciated international body said that it is an important concern and activated the international health regulation. Here again, thank you very much for the WHO, because the international health regulation legal framework helped us a lot, helped us how to interpret the different parts of preventive efforts and how to cooperate on the international scale. Now I think it's going to be time during the summer probably to re-evaluate the value of the international health regulation, and also probably those areas and highlight those which probably haven't served us at best in this new pandemic. New challenges, always new possibilities to change and amend our regulatory concerns. In February, we worked a lot in prevention, and we have a long list of what we've done, how to try to prevent the virus to arrive to the country, how to trace people who were suspected with the virus, and how much quarantine efforts were brought by. We're very happy to share with you with these details. However, I want to bring your attention to the day when the first two cases eventually were detected in Hungary. And this was 4th of March. It took us only around 30 people being sick by the time when we realized that there is a first case when it was a community spread, when we couldn't detect the source. During the first week after 4th of March, we always could detect the source, we could tell which country they are coming from, and we felt on a safe land. However, the community spread always brings a huge uncertainty, and it brought us with this public health thinking that if you act in the first 7 days of a pandemic or of any infective diseases, after the first day of community transmission, you might be in time. And we wanted to be in time, so we acted, and Hungary declared a state of emergency on the 11th of March, and very strict restrictive measures, social distancing measures, protective measures for elderly took place on the 16th of March. What happened, you can see it. Our prediction was what you see on the red line. I don't know whether you see the mouse in my hand or not. So it was, of course, exponential prediction. We took the measures on the 16th of March, and you see after 2 weeks, which we hope that the same as what happened in Wuhan, or very similar things what happened in Lodi in Italy could happen, that our case numbers changed, and it did not follow any longer the exponential expected curve, it followed a different line. So we indeed could restrict the spread of the disease. You see the number of cases, these are the new cases seen since March in Hungary. We always had less than 100 if you look at the curve, the prediction curve, and you see, of course, days when it was well above. There is a huge one here when we detected a big elderly home with a lot of infected patients. Majority of them are well by now and are back in the elderly home. So our forecast is that by mid-July we will have this spread of the disease to end in Hungary, and we can move on with life. We did a lot of preparation on all kinds of areas of society, and here I highlighted those what we took in healthcare. We made a lot of possibility for contactless medical attendance. We allowed to provide prescriptions to the patients without meeting personally with medical doctors. We used a lot of new medical solutions, and the medical society took it very well, and patients liked it, and we trust that it helped us a lot to avoid unneeded meeting between healthcare professionals and also patients. And of course, we made major steps in improving infection control. Many of you might know that we are a country of Semmelweis. And this was the doctor 100 years ago who saved a lot of life of a lot of people by teaching a lot of people to wash hands. And when we are back to those efforts, how we try to avoid the spread of this disease, it brings us back to this 100-year-old knowledge. You can prevent this type of spread of any bacteria, any virus, if you keep washing your hands, and on a societal level, it's more and more. So we done a lot of infection control measurements. We made protection of high-risk groups. We told our elderly doctors stay at home and only provide virtual teleconferences and virtual consultations and not to meet patients in person. And we also made a dual healthcare system separated for COVID and non-COVID patients, and we ensured that the ICU capacities are increased in Hungary to a level where even under the worst case scenario, even if an exponential curve could come by, we could provide enough ventilation to the patients who are needing that. Our C would be a counter and whole of government approach, and some of you already mentioned that. So we try to act together and in a coordinated manner and communicate that. You can see here Budapest, where I would be very glad to welcome you during this summer, which would mean that the world is free again for tourism, to visit each other and to hug each other. But that's how the city was. This is the middle of the city. How it was in April, completely empty. Most of our measures, the containment measures, were only recommendations, but the public took it very seriously, and they collaborated with these recommendations, and they kept their wording. Of course, a lot of experience what the healthcare sector gained from the disease under treatment, and we worked very hard of trying to ensure that we have enough masks and enough ventilators for all of the patients expected. Here are the numbers, the cases and the deaths. On the bottom you see Hungary. These are European countries, and we were among those who took this active choice and who really wanted to avoid the spread of the disease. And by now, I'm happy to say that we were quite able to manage so. We couldn't avoid deaths related to COVID. There were people dying while being infected with COVID, and we have around 500 deaths of COVID disease. We counted everybody who had the virus infection in these numbers, and this is out of a country of 10 million, around 10 million population. We had one person from the healthcare system who died with the disease as well. So we sorry for them, but we happy that in this year until now there were no more deaths than the lowest numbers in the last 10 years since 2010. And after a good 2 months of the first detected case in March, 4th of March, or 6 weeks after these restrictive measures were implemented, we started to move back to normal. 4th of May was the day of reopening the country. And you see the numbers of cases, numbers of new cases around 4th of May. And you see the graph, these numbers are, despite the fact that we started a strict scheduled, feedback given, high vigilance, relaxation measures, but we could keep the numbers low and decreasing. So we trust that we can get to the end of this first wave by midsummer, and we do hope our best that probably even if we prepare for a possible second wave, that still hope that probably this SARS virus will end up in the world as SARS-1, which disappeared after the first wave. So that's my best wishes to all of us. And thank you very much for your attention.
Thank you very much, Minister, for that presentation, and thank you for a timely reminder of Ignat Semmelweis. We in fact have the honour to walk past the statue of Semmelweis as we walk into the office each day, and I think that's a very interesting and timely recognition of his contributions. Now we'll move to the region of the Americas, and we have His Excellency, the Minister of Health and Wellness, Lieutenant Colonel, the Honourable Jeffrey Bostic from Barbados, and I now have the honour to give you the floor, sir. Thank you very much.
Thank you. Good morning, all. COVID or no COVID, greetings from still a beautiful and sunny Barbados. My brief presentation this morning will cover the milestones of our response, the Barbados response of the COVID-19, the economic impact of COVID, and a look forward. And the first thing I want to state is to look first of all at the milestones, and to say that over the last 4 months, my experience has been daunting as Minister of Health and Wellness, as we now face an unprecedented battle against COVID-19 pandemic. Shortly after we in Barbados were made aware of the cluster of pneumonia cases in Wuhan, China, we recognized the critical need to coordinate a response, and as a result, we established a Health Emergency Operations Center, which coordinates a multi-sectoral response team for COVID-19. And this Health Emergency Operations Center reports to an augmented National Security Council chaired by the Prime Minister, with members of civil society, labor, public sector, and other civil organizations. And this is what we've been able to do in terms of an all-country approach to COVID. From early on in the battle against COVID, we determined that we will follow the guidelines established by WHO. That means not to close borders, and that we will not inhibit trade and travel. And that for us has been very, very important in our fight against COVID. During the period, we also were able to establish some new facilities to deal directly with COVID in our efforts to keep COVID out of our main hospitals, especially the geriatric and elderly care facilities. We were able to establish a COVID isolation and quarantine center, as well as a temporary hospital facility utilizing one of our schools. During the period of COVID, we also were forced to go on a national lockdown as a result of a spike in cases that we experienced. This slide shows the situation in Barbados, a country 106 square miles with 290,000 persons. We have had 92 confirmed cases so far, comprising 49 males, 49 females, and 43 males. The age range has been between 7 and 95. We've had 76 persons recovered. There are only currently 9 persons in isolation, and regrettably, we've had 7 deaths. The total number of tests completed in Barbados so far has passed the 5,000 mark, and that number is going to significantly increase as we go forward because of the availability of testing kits. When we first started, we had a limited number supplied by PAHO, and so we had to use those kits very wisely. But we've since expanded our testing right across country because we've been able to purchase a significant number of testing kits, and this is the going forward, this is how we intend to contain the virus here in Barbados. This is the case progression here for COVID-19 in Barbados, and a couple of things I would like to point out. First of all, as you can see here from the graph, that the rate of new cases has slowed significantly. meaning that we have been able to contain the spread of the virus in our country. The acute burden to our healthcare system has been steadily diminishing as cases have recovered. And right now, I can say that we have not had any situation where our healthcare services have been overwhelmed. Disease surveillance for us, that is the key weapon. And we began our surveillance program at ports of entry, and that program was significantly enhanced by additional personnel from throughout our healthcare system to be able to allow us to continue with our tourism industry, which is very important to us, and that has worked very, very well. We began testing at the Public Health Laboratory on the 11th of February 2020, and the test that we have been doing is the RT-PCR test. And as I said earlier, that is going to be expanded and is in the process of being expanded with the availability of several testing kits. But we are certainly hoping for a reliable rapid test, and we are hoping that WHO will be able to advise us on this shortly, because this is going to be very important for us going forward in terms of reopening our borders for international travel. Continued disease surveillance, including augmented lab testing, will certainly remain our key strategy as we seek to test, diagnose, and contain. This graph here shows you our strategy for testing. As indicated earlier, you will see in the first part of the graph that we were unable to do a large number of tests because we did not have the capacity to do so. But as testing kits became available, we've significantly increased testing to include additional testing sites across country, including a mobile testing unit. And we've been able to do a lot of random testing, which has allowed us really to get a very good picture as to what is happening in the country. So we were able to change the criteria for testing about 5 weeks ago, and now doctors are able to send any persons for testing. Additionally, Barbados has sought to improve the capacity of our healthcare system through sensitization and education of healthcare workers, establishment of a hotline, which is ongoing, the procurement of equipment including ventilators and PPE and other medical supplies, and we've increased our human resource capacity by having 100 members of a Cuban medical brigade that are here in Barbados assisting us with our isolation facilities. We've increased the number of community health liaison officers to help us to have a better handle as to what is happening at community level. And we've established healthcare facilities, both isolation and quarantine facilities across country, including an isolation facility which is a refurbished naval facility that has significantly expanded our critical care capacity. And that center, which is up and running, has allowed us to be able to have a primary, secondary, and also tertiary isolation facility. And additionally, we've also deployed our field medical facility to be used as a respiratory center so that we can screen persons before they're allowed to go into the Queen Elizabeth Hospital, especially persons who are seeking surgical operations. And finally, we've been able to create a surgical theater outside of the hospital, which is specifically designated for COVID patients who are seeking surgical operations. In short, our desire has been to isolate COVID from any of our medical facilities, and we've been able to successfully do that so far. The economic impact of COVID has been devastating, I must say that to you, because Barbados depends heavily on tourism. And with international flights cancelled and the country on lockdown, the impacts have been significant. It's a heavy price to pay, but a price that we felt we needed to pay in order to safeguard the public health of our population. So we've been on lockdown now for the last 6 to 7 weeks. The government has been able to provide a lot of assistance to those people who are unemployed, and they're now into tens of thousands. But because of the work that the Ministry of Health and Wellness has been able to do in collaboration with civil society, we have been able to gradually reopen the country to economic activity, and this will continue into the next 2 or 3 weeks. And there is a position taken by the Caribbean community to reintroduce inter-regional travel and trade, and that is going to be our first step towards reopening borders before we allow international travel, and also before we restart the tourist industry, which is, as I said, critical to the economic well-being of Barbados. And of course, if the economy is not functioning on all cylinders, it will have a negative impact on the healthcare system in general, outside of COVID, and this is something that we are very, very mindful of. You can see on this slide the combined effects of the economic activity significantly reduced, and in terms of foreign direct investment and a lot of the projects that we were hoping to do, this has really halted our progress, especially during the fact that we are in a current program with the International Monetary Fund. So we have to seriously balance between COVID and also the ability of our people to be able to work and to be able to eat. And this is something that is engaging the government as I speak. And one of the lessons that we've learned from this entire experience is that a lockdown on its own will not prevent the spread of COVID. And similarly, the reopening of the economy on its own will not cause a spike of COVID. The glue for us that holds it all together are following those protocols established by the WHO, which we've been really following in terms of physical distancing, personal hygiene, and doing all of the things that are necessary to keep people safe. And this is really where we intend to go going forward. We have a policy in Barbados that there will be no retreat or no surrender to this virus. It's an unseen enemy, and we are going to defeat and overcome this enemy by all means necessary. We are gradually and carefully coming out of our lockdown phase and opening up Barbados as we adjust to a new normal. The healthcare teams will remain vigilant. We will continue disease surveillance, testing and diagnosing possible cases as we seek to mitigate against COVID. The impact, yes, has been devastating, but we will overcome. Barbados is very grateful for the guidance provided by the WHO regarding adjustments of the public health and social measures for COVID-19, and we are sure that with the assistance of WHO, PAHO, and the international community, and working collectively with our CARICOM neighbors, that we will continue on the upward trajectory in terms of combating COVID. I thank you.
Thank you very much, Minister Bostic, for that presentation. That brings us to the end of our presentations from member states this morning. I will now ask that Jude, as usual, will help facilitate and moderate the questions from the participants. So over to you, Jude, and we look forward to taking your questions and either having the member states who presented today respond, or the technical experts we have in the room here today. So Jude, if you could assist, please. Over.
Thank you, Dr. Armstrong. As is the practice, we would humbly request that countries that wish to ask the question kindly use the raise the hand button so we can identify you and give you the floor. At the moment, we do not have any, but I guess we could give ourselves a few minutes to see if the raise the hand button could come up. Okay, we have a question from the UK mission, and then I'll go to Mongolia. UK, you have the floor, please.
Thank you very much. We thank Member States and Ministers for their presentations, and we find the sharing of this information and lessons learned very useful. A globally accessible coronavirus vaccine and effective treatments and tests are needed to end this pandemic and to start global economic recovery. We need a truly global effort to do this, because no one country and no one pharmaceutical company will be able to do this alone. On the 4th of June, the UK Prime Minister will host the Global Vaccine Summit, bringing together leaders from around the world at a virtual event to pledge their support to Gavi, the Vaccine Alliance. Gavi is a crucial partner in the fight against infectious diseases globally, including coronavirus. The summit aims to raise at least $7.4 billion to help Gavi protect a further 300 million children against infectious diseases like measles, typhoid and polio, and to save up to 8 million lives over the next 5 years. How important is it that donors pledge support to Gavi at this critical time? Thank you.
Thank you very much, Nicola. May I invite Mongolia Ministry of Health? You have the floor, please.
On behalf of the Ministry of Health of Mongolia, we would like to ask to all countries that mentioned as such, the effectiveness of separating COVID-19 versus non-COVID-19 hospitals, as well as the risks of of not separating them. Thank you.
Thank you very much, Mongolia, for your question. Would any of our presenters be in a position to respond? Would you like the question to be repeated again? Mongolia, could you kindly repeat your question again for the benefit of our listeners?
Yes, the question has two parts. The first part is, what is the effectiveness of having a designated COVID-19 hospital? And the second part is, what are the risks of not separating the hospitals?
100%.
Okay, thank you. I think in the presentation from Bahrain, there was a mention of having a separate hospital. Bahrain, would you like to take this question, and then perhaps I'll move to the Honorable Minister from Hungary. Bahrain, you have the floor.
Sorry, I had some technical issues with unmuting myself. So basically, it depends on what kind of facilities you are transforming to become these corona dedicated facilities. So there is obviously a risk according to the engineering of the facility itself. If there's no negative pressure rooms, there's no separate ventilation, then you cannot mix the COVID-19 and non-COVID-19 patients. There's also the case of severity of your COVID cases. If they're asymptomatic, young of age, no medical complications, then you might put them in treatment facilities that do not necessarily cater to ICU settings. But then there are other facilities that are solely dedicated to ICU patients. So that's where our separation came from. So we had 2 facilities dedicated solely to COVID-19, and that's because of the lack of separate ventilation. So they're only COVID-19 patients facilities. Then there are facilities that are offering ICU services only dedicated to symptomatic high-risk COVID-19 patients. Other facilities are more or less isolation centers rather than treatment centers, where the patients are monitored by medical professionals, but not necessarily equipped to deal with high-risk ICU cases that need ICU. So that's where our separation came from. But then again, it depends on your country's plan and the setup of the facilities that you cater or that you dedicate to your COVID-19 patients.
Thank you very much, Bahrain, for that cogent response. I understand we have questions actually from some of our technical colleagues in the room. I would give the floor to Maria.
So thank you so much for these really excellent presentations. It's so wonderful for us to see how you have tackled this virus and this pandemic and implemented these prevention and control programs. So congratulations to all of you, and thank you for your willingness to share that with us. I do have to say I love the no retreat, no surrender from Barbados. I think we might need to use that ourselves. I did have a question around, it was a question for Nepal around the isolation and quarantine of cases. That was quite a large number, and I was just wondering how you were maintaining that level of quarantine. I would imagine that would be quite a burden on the system. Thank you.
Thank you very much. Oliver, do you have a question? Please proceed.
Thank you very much. I'd like to reiterate my thanks to all the presenters today. It's just a great set of presentations. I was very interested with the particular point made by Bahrain about the criteria that they're using to adjust their public health and social measures. And it looked on the slide like they have a scoring system of 1 to 5. But I was wondering if you could just provide a little bit more detail about how they are making that assessment to adjust their public health measures. Thank you very much.
Thank you very much, Oliver. There was a question posed by Maria to Nepal, so we can go to Nepal and then we'll come to Bahrain for the second question posed by Oliver. Nepal, you have the floor, please.
Thank you, Maria, for the question. Yes, we are definitely having a very difficult time at present with the number of people, migrant people working in India coming back to Nepal, especially in the border areas. So at present we do have around 30,000 quarantine units, but unfortunately the facilities out there at the units are quite poor. So we've been working very hard in order to make certain facilities as quickly as possible, especially with the sanitation part and safety of the people. And if the climate at present is very warm, let's say it's very humid and warm, so we are worried about all the things that are there in the quarantine areas. So it's a very difficult time for us, and we are still in a very difficult situation of whether to directly checking them for, doing their PCR without any complaints, keeping them in quarantine for around 14 days and then taking them back to their homes, whether we should do some sort of testing and send them home, There's a big confusion out there, but the government is making an overall clinical plan so that we can accommodate them properly in the quarantine areas and then send them to the local areas where they are quarantined for around 14 days, and then they are sent back home if there are no signs and symptoms in them. And we are planning to do a mass rapid diagnostic testing after 14 days of quarantine. But excuse me. But it's quite difficult for us to get all the things ready in order to do the quarantine, in order to do the testing to the quarantine people and sending them home. So it's a very big difficulty time for us, and we're still looking for some sort of advices and some sort of guidance to how to move forward. Thank you.
Thank you, Dr. Pokharel. I would move to Dr. Al-Shaban, and then I recognize Thailand who's raised their hand. So, Dr. Al-Shaban, you have the floor, and then Thailand, please.
Thank you, Mr. Chair. So just to go back to the slide with regards to our assessment parameters. So just a little disclaimer, there's no obviously right or wrong answer here. It's all a work in progress, and we're still learning from this virus and this pandemic. But what we've opted to do here at the National Task Force is we set, like I mentioned in my presentation, a number of items that we used as parameters to ease our restrictions or make them more strict accordingly. We had a scoring, or we have adopted a scoring of 0 to 5 according to each parameter. And when I was talking about the parameters in my presentation, I mentioned the most favorable, and that is a score of 0. So let's say if we talk about the cumulative number of cases, if the cases don't increase by 100% within 2 weeks, we give that parameter a score of 0. And then let's say it doubles within 5 days, then we give it a score of 5, the highest score. So the idea is to achieve the lowest score possible. So if we achieve between 0 to 10 within these parameters, according to our adopted framework, then it is a go-ahead for us to ease our restrictions. But if our scoring is at, let's say, 50, then we need to move towards more strict measures. Obviously, we present this to the highest authorities here in the kingdom, and then the decision comes from that authority. According to our assessment, our latest assessment that we presented, we have achieved a score of less than 10 according to the parameters. Again, I stress subjective parameters that we put forth. There was a decision to ease some of the restrictions, but not all of the restrictions. This is still a work in progress, but we have noticed that this has worked. In the beginning, we solely based our decisions on the influx in cases, and we found that there was certain influxes when for instance, there were the initiation of the repatriation program for citizens. A lot of the imported cases were positive, so we noticed some peaks. Another peak was when the infection spread within blue-collar worker camps because of the living conditions. That was another peak, but we did not regard or consider other parameters at that point. So we realized the importance of it being a comprehensive assessment of all parameters, not only with regards to number of cases, but also the number of recoveries needs to be factored in, the number of available beds, and even when we're saying that the bed is occupied, is it occupied by a symptomatic patient, a patient that requires ICU staff and ICU services, is obviously a different criteria. So at this point, we are at 0.09% ICU occupancy rate. We are at 12.5% symptomatic rate. So all these scores are in our favor with regards to easing the restrictions. So that's it in a nutshell of how we are assessing our mitigation measures. Obviously, if these scores change, and they're being assessed continuously, so if these scores change, then policymakers will obviously make different decisions.
Thank you very much. Could we now invite Dr. Suit from Thailand to take the floor? You have the floor, sir.
Thank you. Thank you for such an excellent series or weekly session that are very informative.
We would get back to you on that question. I don't imagine it was targeted to the member states who made the presentation. I think it's more to the Secretariat, so we will have to take that on notice and revert at the appropriate time. In the absence of any further questions, I think I would have to revert and give the floor back to the chair. Thank you, Dr. Armstrong.
Thank you very much, Jude, and colleagues for those presentations and questions and answers. And certainly there was some very interesting material today, and interesting, Dr. Suit, as you mentioned, each week to notice that these information sessions, sharings from member states are beginning to cover an even increasingly diverse range of issues, not only just in relationship to the epidemiology and the immediate response. We heard a little bit today about some of the mental health aspects, the mood of the people in countries, the information and countering misinformation that's being spread in countries, and what governments are doing in order to combat that, and including from at least two of the presentations today, some of the impacts that this pandemic is having on the economic situations within countries, and particularly countries who depend on tourism, for example, for as a large part of the economy. But with that then, DG, do you have any final comments you'd like to make today, or Mike or other colleagues? No, DG, I think the floor is...
Okay, thank you. Thank you so much. If there are no further questions, then I would like to thank all member states who have presented today, especially the ministers and others representing the ministers for their excellent presentation. I think we have learned a lot from their experience, and as we have been saying, this virus still will stay with us, and getting the lessons regularly and readjusting our strategies and making our response more effective based on the lessons learned is very important. As you know, when we started, there were many unknowns. Now there are more knowns, and the unknowns are minimized. But still, there are many lessons to learn from our response, and we should continue to learn as much as we can in order to improve our response and ultimately end the pandemic. So thank you so much from WHO side for this platform. Of course, we will continue from our side and look forward to having the next presenters next week. And until then, thank you so much again. Team, back to you.
Thank you again, DG, and a final thanks to all colleagues that joined from capitals, from here in Geneva. And just a thanks, this is the first time that I've had an opportunity for all those member states for their engagement during the WHA and the Executive Board last week on behalf of governing bodies and the colleagues here. Thank you for helping us to collectively have a first ever virtual governing bodies meeting here in Geneva. With that, I look forward to seeing you again next week when we have the next round of the member state information sessions on COVID-19 response, and Jude will be working with member states interested in presenting next week. So with that, I bid you a very good afternoon, evening, and good night.